SPPA, and also to the chairman of CIMCO, Consortium of Islamic Medical Colleges, Dr. Iwang Yusuf, MSE. Before we start the seminar, let us all say Basmalah. Bismillahirrahmanirrahim. As for the schedule today, first we have a welcome speech by Dean of Medical Faculty of Universitas Muslim Indonesia. So to Professor Dr. Haji Syarifuddin Wahid, PhD, SPPA, Konsultan SPL. We would like to give you the time for the welcoming speech. Professor, time is yours.
Please, thank you very much. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Alhamdulillah. Wa syukurillah wa la haula wa la quwwata illa billah. Hasbunallah wa ni'mal wakil, ni'mal maula wa ni'man nasir wa la. On behalf of the Faculty of Medicine, Universitas Muslim Indonesia, I would like to express our thank you very much, our appreciation first to the FOKI, Forum of Indonesia Islamic Medical School, who give us a chance to running this first CIMCO online seminar. It is big honor for us to running this very important seminar. And also I have to express my thanks very much and appreciation to all of the speakers coming from various countries. From Malaysia, we have Prof. Abdul Rashid, our friend, so long time.
Jazakallah.
Assalamualaikum, Prof.
Waalaikumsalam warahmatullahi wabarakatuh.
From Pakistan, we have Prof. Iqbal, MKan. Assalamualaikum, Prof. Iqbal. From Turkey, we have Prof. Hasan Kuplu. Assalamualaikum, Prof. Hasan. And from Indonesia, we have two speakers, one from Universitas Muhammadiyah Yogyakarta, Dr. Kus Barayanto, and the second one from our faculty, from Faculty of Medicine, Universitas Muslim Indonesia, Dr. Edward Pandu. He is a pulmonologist consultant. And also, I have to welcome for all the participants, all the participants for the seminar, attending the seminar. I think it is coming from very much Faculty of Medicine in Indonesia as well as abroad. I hope all of you will attend the seminar. We will have so many benefits from the seminar coming from excellent speakers around the world. And last but not least, I have to thank to the organizing committee to perform this very excellent seminar, international seminar. And may God help us to running all in the best condition. Thank you very much. And again, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Professor Syarifuddin Wahid. And furthermore, we continue to the first speaker, the presentation, the first presentation. And this presentation will be delivered by Professor Dr. Abdul Rashid bin Abdul Rahman. He is a cardiologist internist from An-Nur Specialist Hospital, Malaysia. And the topic that will deliver by Professor Abdul Rashid is COVID-19 with hypertension and CVD Malaysia experience. Professor Abdul Rashid bin Abdul Rahman now is the General Secretary of FIMA, Federation of Islamic Medical Association, from 2019 to 2021. But also he's a General Secretary of FIMA. The first time I met Professor Abdul Rashid. Okay, for Professor Abdul Rashid, I think I will deliver the time for you to present your presentation, and until we will wait the committee to share the screen from your PowerPoint. Please, the committee.
Bismillahirrahmanirrahim. Whilst waiting for the slide, I would like to thank Allah Subhanahu wa Ta'ala for making this session a possibility. Jazakallah khairan to Dr. Iwang especially, and for Umi for hosting this. This is what we call the new normal. We will be meeting more frequently like this, inshallah. And may Allah Subhanahu wa Ta'ala make our linkages stronger, because we can hopefully meet more frequently online like this. So I was asked to talk about hypertension and COVID specifically, and cardiovascular disease generally. Can you get my slides out?
Yeah.
Okay. Can I control it from here?
Of course, sir. You can control from there as well, but
okay. So you can
I have no idea.
You can see my arrow, my pointer. Can you all see?
Not yet, okay, sir.
Okay.
Professor, yes.
Anyway.
We will wait until the committee.
Okay.
Share your slide.
Yeah.
Please give us time.
For the information of members of FOCI and CIMCO, FIMA doing a few activities towards contributing to the, if you like, I don't like to call it a fight. It is from Allah Ta'ala, so we have to learn lesson and try and improve ourselves. That's why I don't like the word fighting COVID, crusade against COVID. I don't think these are right words to say. These are lessons Allah Ta'ala wants us to learn from. Most important thing, do not be like Donald Trump. He's so arrogant. And so is Bolsonaro.
Being arrogant. Donald Trump being so arrogant.
That's why they are facing all this problem. Anyway, the FIMA Exco has been meeting very regularly to touch base and find out what's happening in different parts of the world where FIMA members are there.
Kenapa bisa terhubung ke kita? Site limit itu yang khusus untuk seminar-seminar.
Siapa itu begitu?
I think there's a lot of background noise.
Itu yang saya pakai khusus kalau mau seminar-seminar.
Tutup dulu itu ya.
House, please.
Yeah, I think it's
unmute
better.
audio.
Yeah. Okay. Anyway, can I start?
Yes, Professor. Yes,
okay.
Of course you can start.
I can control the slides, huh? Bismillah. Okay.
Okay.
I will start with a case presentation. Oh, I cannot control the slide. I press enter, it's not moving.
Oh, yes, because
okay,
the slide has been shared from here.
Okay, so you can control for me. Can I have the first slide, please?
The committee, Dr. Tomo, please. Dr. Tomo, please, the slide of.
Tomo, atur slide-nya itu.
Okay, Jazakallah khairan. So can I have the next slide, please?
Slide berikutnya.
Okay, so I will begin with a case. Okay, are we ready?
Yes.
I think there's a lot of background noise. Maybe everybody except for the organizer should mute. Inshallah. Anyway, I saw a 50-year-old man in March, early March. He already has hypertension for 14 years, and he was taking a drug called valsartan, which is an angiotensin receptor blockade. He came to the A&E department of my hospital because of fever and headache and myalgia, very non-specific symptoms of 5 days duration. A dengue test was done in A&E in the emergency department, and it was positive. It was positive for the antigen. And so the patient was admitted to the ward, because in Malaysia, most dengue patients are admitted, especially if they have warning signs. He did not have warning sign, no vomiting and no diarrhea, and there's no abdominal pain, but his blood chemistry, especially his hematology, was not very good. A day after admission, he started to cough. He has no asthma and no allergy, but the cough was very tolerable, no sputum at that time, and the lungs was basically clear at that time. And then on the second day of admission, he starts to have watery stool. And watery stool is one of the warning signs of dengue, especially if it recurs about 3 times or more in a day. And then the following day, the diarrhea was treated symptomatically. The following day, he started to have spike of temperature, but his diarrhea has improved and his cough was getting better. But on the 4th day, I was in clinic, and I finished my clinic. I went to see him in the ward, and the nurses told me that he just came out of the toilet and he was very breathless. And his oxygen saturation dropped to 89%, and he had to be given oxygen via nasal probe and then facial mask. And this time his lungs showed, there was crepitation, fine crepitation in both lung fields, which was not there before. I immediately transferred into ICU, repeated the chest X-ray, and the chest X-ray showed alveolar opacity, which is more widespread. So I immediately thought about COVID-19. Next slide, please. Can I have the next slide? Yes. And why did I have to think about COVID-19? Well, at that time, early March, the country was experiencing a wave of COVID-19. We were doing well before that. There was 7 days, no cases at all. But after a tablighi gathering in near Kuala Lumpur, many brothers who attended that tablighi gathering, developed COVID-19. And when I asked the history in more detail, he admitted that before he came to our hospital, he actually went to see a GP because of fever and myalgia. And the GP, the husband, attended the tablighi mission, and a few of his tablighi friends went to see the wife, the GP. And 2 of the patients who visited that clinic turned out to be COVID positive. And one of the patients was actually my patient's work colleague in the same corporation. Although he told me that he never come into contact with this COVID positive patient. So the Ministry of Health of Malaysia actually asked the clinic to be closed, and the doctor and the husband were quarantined and tested for COVID. The other reason why I thought this could be COVID, because his X-ray was worsening. There were more alveolar opacity, and we have to take that seriously. And his SpO2 dropped very fast, very dramatically. The other thing is that about the same time, there were 2 cases of dengue fever diagnosed as dengue in Singapore, which turned out to be COVID. And the Singaporean colleague actually published them in the Lancet. So it was a major discovery, if you like. So all of us looking after dengue, we physician and pediatrician now get a bit concerned, because dengue can actually mask itself as or rather COVID-19 can mask itself as dengue. Also, my patient has got hypertension, cardiovascular risk, and his absolute lymphocyte count was dropping below 1. These are all, bad sign that this may be COVID. And also he was on ARB. And at that time, there was already a fear that ARB users can actually invite the virus to latch on the AC2 receptor and enter the cell. Next slide, please. So I contacted the National Infectious Disease Referral Center. In Malaysia, only certain hospitals can look after COVID. In Malaysia, all COVID positive must be admitted. They can only be admitted in government hospital and some teaching hospital, not all teaching hospital. Private hospital cannot manage COVID patient. So when I told the story to the infectious disease physician on call, he said, yes, bring the patient over. He sounded like COVID, and the full COVID protocol was instituted to the patient. Next slide, please. So this is the current situation of COVID-19 as of 2 days ago in Malaysia. Alhamdulillah, we are very thankful to Allah subhanahu wa ta'ala. In early March, we have the largest number of patients in Southeast Asia, but now we have the lowest. We have a very good outcome, 97% plus recovery rate, only 1.39% mortality rate. And now we have very few cases. In fact, 2 days ago, 18 was a lot. Usually it's below 10 now. And as you probably know, our Director General of Health has been given a lot of awards, including the recent Brand Laurel Award for managing to tackle the COVID threat. Actually, the Director General of Health said at least twice that the preparation to tackle COVID in Malaysia started in December 2019. So it was a very planned approach, and alhamdulillah, we are one of the better countries in terms of COVID. And in Asia, as you probably know, the mortality rate in Asia is much lower than in the West. And in Asia, the countries with the lowest mortality rate includes Malaysia, Singapore, and also China and Taiwan. Next slide, please. Well, this is the ex-Minister of Health. You may know that Malaysia has got a very unfortunate political coup d'etat during the time of the COVID. In fact, the government change took place on the 18th of March. And that just before the 18th of March, when my patient was admitted. And on the 18th of March, the country went into a lockdown. We call it movement control order. It was a lockdown. And the police were very strict with this. People were sent to jail if they do not follow orders. They were fined. Many people were fined. 1,000 ringgit, that's a lot of money. But the minister at that time, who at that time was no longer the minister, told me, he's my good friend, he said, well, the health challenge in Malaysia is not just COVID. There's lots of other things. Next slide, please. For example, if people are concerned that people are dying from COVID, well, in Malaysia up to today, only 122 people died, alhamdulillah, very low. 1.something% fatality rate. So between January and June this year, only 121 deaths in Malaysia from COVID. But if you look at ischemic heart disease death from January to June 2018, this is the latest figure. 2019 figure is not yet released. Oh, there's some noise. There was 9,133 deaths. From ischemic heart disease, there's 50 deaths a day. So ischemic heart disease is much more of a problem. COVID, of course, is very emotive because it is a global pandemic. It spread very fast, but in terms of fatality in Malaysia, it's actually very, very low. Next slide, please. And in Malaysia, if you look at this graph, these are causes of death in Malaysia. This is quite old data, 2010. In Malaysia, every 10 years, we do this study called the burden of disease study. So in 2010, hypertension is the #1 killer for male, 19.4%, and also for female, which is 22.8%. In male, the second commonest cause is smoking and diabetes, #3, and high cholesterol, #4. In female, the second commonest cause is diabetes and cholesterol. So in terms of health in the country, the non-communicable diseases are actually more important and more deadly. Next. Just to remind you, cardiovascular disease is the #1 cause of death worldwide. And the biggest contributor to cardiovascular disease is hypertension. There are 1.4 billion people with hypertension in 2019. One in three people in the world have got hypertension. And it's the #1 killer worldwide, all over the world, except for some advanced country where cancer is now #1. And 60% of hypertensive patients are taking a drug called ACE inhibitor or ARB. Next. Oh, sorry, it doesn't come out very nice. It was okay when I sent it. Basically, the prevalence of hypertension has come down, alhamdulillah. In Malaysia, every 5 to 4 years, the government spend money to do a national health survey. And alhamdulillah, the prevalence has come down from 2015 to 2019. It's now 30%. Smoking has also come down. Hyperlipidemia has come down. Now it's 38.4%. But diabetes is the only cardiovascular risk factor which is still not coming down in Malaysia. Next. And when we look at hypertension in the country, we found that, alhamdulillah, now more Malaysians are aware they have hypertension, 50%. 50% of Malaysians who've got hypertension are aware. In other words, their doctors managed to diagnose them in time. And 90% of them who have been diagnosed are getting treatment. This is one of the best figures in the world. The country which is as good as this is Canada. Canada has got 80% treatment rate. America has got 75% treatment rate. But most Asian countries, the figure is very, very low. So this one, we have to do something about it. However, although the control rate is getting better and better, but we are still far behind. In Canada, 80% of those on treatment are controlled. In Asia, no country touched 50%. Very few countries touch 50%. These are the smaller countries like Singapore, where it's easier to monitor control. Most other countries is about 20, 30%. Inshallah, in Malaysia, is 47%. Hopefully, we will touch 50% and above that, inshallah. Next slide, please. Now, it is very important to remember when we talk about death, especially when we talk about premature death, people who die when they're still supposed to be alive, doing good things, doing ibadah, amal saleh, doing infaq, you know, but they are dying. And they are dying mainly because of cardiovascular disease at a young age. In Malaysia, the mean age of the first heart attack is 58 years old, 58 years old, about 10 years younger than in the Western population. You see, in the Lancet, 2 years ago, Muhammad Pateh has said that substandard care is responsible for 84% of cardiovascular death. This is very unfortunate because these are preventable death, inshallah. 81% of vaccine preventable death and 61% of post-birth complication. Of course, post-birth complication get a lot of attention because these are young people who shouldn't be dying. Vaccine preventable death has got lots of emotional publicity, again, because these are young people who shouldn't be getting disease, and a small percentage of them will die. But for hypertension and cardiovascular disease, these are people who are still supposed to be working. Mean age is 58, but they die. And when they die, 84% of the time is because the doctors are not treating them properly. And it's very unfortunate. So we doctors, especially those of us in FIMA and FOKI and CIMCO, must make this our target, that when we treat our patient, we must treat them optimally. Inna Allah katabal ihsana ala kulli shay. For Allah demand you to do the best in whatever you do. As a healthcare worker, we must do the best, not just substandard care. Next slide, please. Okay. Now, come back to COVID. As you know, there are millions of people with COVID. We are waiting for lots and lots of publication about COVID. It is only about 6 months old disease. and we're waiting for more papers to be published. However, the first few cases, 44,000 cases from China, showed that of the confirmed cases, 12% of them were hypertensive. The biggest concomitant risk factor is hypertension, followed by diabetes, then cardiovascular disease, then chronic respiratory disease, and cancer. But if you look at those who died from COVID, almost 40% of them have got hypertension, 20% diabetes, 22% cardiovascular disease, 8% respiratory disease, and very small number with cancer. So this disease likes people with comorbidity, especially cardiovascular comorbidity. Next slide, please. And based on our understanding of this new disease, we know that the SARS-CoV-2 virus like to attach itself to angiotensin converting enzyme 2 receptor before it enters the cell. So that is the door through which it enters the cell. And once it enters the cell, as you know, it takes over the genomics of the cell and produces more and more virus, and it kills the very important cell and causes inflammation. So the question we scientists have is that what is the role of ACE in disease progression? ACE2 receptor. And number two, if we treat patient with ACE inhibitor or ARB, will we increase ACE2 expression? Some people say yes, some people say no. Interestingly enough, there was a study to show that among children and young people, they do not have an overexpression of the ACE2 receptor, and that may be a reason why they are protected if they got infected. And the question people ask is, will treatment with ACE or ARB impact on COVID outcome? In other words, will patient taking ACE or ARB more likely to get complication and die when they get COVID? And lastly, this brings a very important question. Could there be a new therapy, not just antiviral? Can we find a blocker of ACE2 receptor? And hopefully when we block the receptor, the virus, although the virus enter our body, it cannot bind to any cell and it cannot enter any cell. So these are the hypotheses which has been generated in the first few months of this disease. Thanks to the scientists who did all the work. Next, but this is question mark. Remember, they are all question mark. Next. Next slide, please. Okay, in Malaysia and in most part of the world, I told you 60% of the patients are on ACE inhibitor and ARB. You can see from our guideline, many patients with hypertension and with concomitant disease, we recommend to take either ACE inhibitor or ARB. It is a treatment of choice for most patients, either as a monotherapy or next slide, please, or as a combination therapy. Next. This is an article I wrote 5 years ago about hypertension in Asia Pacific region. And the third point, we said that we recommend in the Asia Pacific region, if patient has hypertension and they need to be controlled with combination therapy, the combination therapy should include either ACE inhibitor or an ARB if the patient cannot tolerate ACE inhibitor. So lots of patients will be on this drug. Next. Next, please. And next. So we have a dilemma. Next, please. COVID is new. Next, please. Yes. So we are very worried that there may be too many patients on this drug and which may impact on their outcome. Last month, there were 2 important studies on this because this, as you see just now, there are lots of question marks. We do not know. So when we do not know, when we do not have randomized controlled trial, we have to base on observational study. 2 observational studies were published in very good journal a few weeks ago. One again from China, where out of the 2,877 patients with COVID who were hospitalized, 30% of them has got hypertension. So now we know it's small. Just now, I told you it was less than 10%, now it's small. However, alhamdulillah, the study found that the relative risk of death was increased by 2-fold. Although it was increased by 2-fold in hypertensive, not alhamdulillah, 2-fold. Just now it was more than 2-fold. So when the bigger data came, the figures looks a bit better. But more importantly, those patients with history of hypertension, but not being treated with antihypertensive, has a higher risk of dying compared to those receiving antihypertensive. And very reassuring, there was no difference amongst those who received ACE inhibitor or ARB compared to those who did not receive. So there's some reassurance there. And the paper also showed that when they pulled together 4 studies from China, If anything, patients taking RAS blockade are protected from dying compared to those not taking RAS blockade. Again, I must remind you, this is an observational study. This is not the definitive evidence. But since it's a new disease, we are waiting for new data from randomized controlled trial. We have to go by this for the time being. Next slide. Another study again from China last month, say, very important journal, Circulation Research, one of the top journals in cardiovascular medicine. They look at more than 1,000 patients with COVID-19, and they found that if anything, alhamdulillah, very reassuring, the all-cause mortality in the 188 patients on ACE inhibitor or ARB was actually lower than those not taking this drug. So very reassuring from last month onwards that don't worry too much at the moment for the time being until we get the randomized controlled trial. Next slide, please. So from the first two observational study, there was no harm from RAS inhibitor in patients with COVID. However, being observational, it does not answer questions definitively. There are some questions yet to be answered. For example, what type of antihypertensive medication should be given if this patient has got COVID and hypertension? And could such medication lessen the mortality even, not just increase the mortality? And will RAS inhibitor use affect the risk of infection from virus? In other words, a patient already on RAS inhibitor, are they more likely to get COVID if they were exposed than patient not on RAS blockade? Next slide, please. And alhamdulillah, in the Lancet, a few days later, this paper was published. This paper looked at a huge number of patients with COVID, huge control group, 10 times the index group, and it found that there was significantly higher CVD and CV risk factor in COVID patients. We know that. Users of RAS inhibitor are less likely to require hospital admission. Again, very reassuring. So they're not more likely, but they are less likely. Again, based on this observational study. And there was no increased risk was observed in those taking ACE inhibitor or ARB. And even among the diabetics with RAS inhibitor, there was a lower risk of being hospitalized for COVID. And there was no association between RAS inhibitor use and the severity of COVID. Very reassuring over the last few weeks from all this paper in very important journals. These are all top-notch journals. Again, I must remind you, this is an observational study. Next. Next, please. So the conclusion from the third study was RAS inhibitor use does not increase the risk of hospitalization for COVID. RAS inhibitor use does not increase the severity of COVID-19, and RAS inhibitor should not be discontinued because some doctors were worried. They even stopped these drugs. So you should not be discontinued in order to prevent or mitigate COVID illness. Next slide, please. So I'm coming to my end. As I hinted to you, this is our observational study. It's a new disease. We are still understanding the pathogenesis and mechanism. We need randomized controlled trial. There are thousands of randomized controlled trials with COVID patients. Different types of studies being done to answer questions prospectively in a hypothesis testing experiment. Observational studies are only hypothesis generating, not hypothesis testing. For hypertension, these are the three trials we are waiting for. One is a trial looking at losartan. In patients with COVID requiring hospitalization, we give them losartan or we give them placebo to see whether giving them ARB can even improve the outcome. Of course, the study was approved by ethics committee because there was an equipoise. There was a question which needed to be answered, and the mechanism points towards a possible benefit. And as I told you, now that we know the virus attached to the ACE2 receptor, I hinted just now, what if we can find a drug which will block the ACE2 receptor, and the drug is being studied now, is recombinant human angiotensin converting enzyme 2, and they are being studied in patients with COVID to see whether it can improve the patient's outcome. And lastly, a trial which will be published, which will be presented in Amsterdam next month, end of next month. I was supposed to go there for the European Society of Cardiology, but of course nobody's traveling. Maybe we will attend by webinar. The first trial will be presented. These are patients with COVID, and they are randomized into either continuing the drug if they are on the drug already, or stopping the drug if they are on the drug. And then we will know whether we should stop or we should continue the drugs, the RAS blockade, if the patient is already on them and they are being hospitalized for COVID. Lastly, I think that's the last slide. Last slide, please. Yeah, I think that's it. So what I've tried to do was to go through some of the controversies regarding COVID and cardiovascular disease, especially hypertension, because it is still a controversy. But at the moment, for those patients with hypertension, all the expert society have told doctors, do not stop the drug yet. Continue the drug because ACE inhibitor, especially an ARB to some extent, these are life-saving drugs. And patient dies of cardiovascular disease much more than they die of COVID. Wallahu alam. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Professor Abdul Rashid. That was a very great presentation, because I think that was a new one for me. And the point I can take from your presentation is that we should not stop the treatment for this hypertension patient, because there is such a research that we can still continue the treatment over the COVID-19 diagnosis. Okay, so would you like to permit questions from the audience, or
I
probably
leave
we
it
continue?
to the moderator. Do you want to finish all the talk first and then ask questions?
Okay, I will ask first for the audience. Is there any question to Professor Abdul Rashid? Or maybe I just left the, I will just leave the questions at the end of this session. Okay, please, if there is questions from the audience. Professor, I think, yeah, I think probably we will go to the next presentation first. Probably the audience still prepare their questions, or maybe they want to combine to the other presenter, and then they will make their own questions. Okay, for the next presentation, we have here Professor Muhammad Iqbal Khan, MD, from Shifa Tamir Al-Milad University, Pakistan. Professor Iqbal Khan will deliver the topic, Managing Surgical Emergencies in COVID-19 Pakistan Experience. Professor Iqbal.
Okay. Bismillahirrahmanirrahim. Much Islam. Briefly, inshallah, discussing the Pakistan experience and maybe in general it should be shared with everyone. First of all, I welcome the CIMCO initiatives, and I believe that we should need we should have such webinars continuously, maybe fortnightly or monthly basis, because this problem is not going to end up very soon, as I understand here in Pakistan. But one of the important aspects is that we should be sharing our experience from one country to another country with our brothers, because we have probably similar type pattern of the disease in Asian countries at least, and in all over. I will be basically sharing some of the management of the surgical emergencies. This is very important, and maybe I will share with you the impacts of the current pandemic on the healthcare system as a whole, challenges that COVID poses in the healthcare environment around the world, and guideline to healthcare individuals to plan and prepare the required facilities by the hospital and healthcare system. And what is the best practice in Islamic approach there? First of all, I just want to share with you the Pakistan situation. In Pakistan, the cases are now declining. We had 262,000, in excess of 262,000 patients, but fortunately, 200,000, nearly 200,000 patients recovered completely from COVID. And our mortality rate is around 2%, and that's include everything. And now we are on decline. Our cases are declining day by day, but soon we are going to meet inshallah Eid al-Adha. If we will misbehave in Eid al-Adha as we misbehaved in Eid al-Fitr, everything rises in Pakistan after Eid al-Fitr, because before Eid al-Fitr we celebrated the Eid with full force. There were crowds everywhere in the country, in bazaars, in streets, in cities and villages, and ultimately we end up with the very sharp rise of the cases in Pakistan, and that end up with the massive mess in Pakistan as well. Now, currently, the things are under control because of the smart lockdowns and so on and so forth. But still, we are very conscious, and I am delivering at least 4 to 5 seminars before Eid on how to carefully we behave at Eid. It's very important that we celebrate the Eid and we end up with the mess in the country. I just want to come back to my topic very quickly. I want to share with you a very interesting case. A 23 years old gentleman had a firearm injury of the femur and upper, and he actually injured his upper superficial femoral artery, and causing acute limb ischemia. On the morning of the Eid al-Fitr, you see, I prayed Eid al-Fitr and then went to manage this patient. And when he sustained this injury, he was standing on a wall and he fall down, and he had a head injury as well. In a emergency room, he was immediately suspected a case of COVID as well. So on the basis of CT scan chest, which they did, and it was later on confirmed after the operation by PCR as well, under which 6 hours fully protected ortho and vascular procedures, and followed by care in the COVID critical area, and alhamdulillah, fully recovered. So I just want to share with you that why this is important, that we should be having some protocols while managing the surgical emergencies. Now, we're talking about the surgical emergencies. We need to provide the timely care to these patients, number one, and we should be knowing there is no sound substitute of surgical care other than anything else. And while taking the surgical care, we need to take certain precautions, and I'll be quickly going through those precautions. And while we are asking for the multidisciplinary decisions to be made, then what precautions should be taken at that time as well? We have a few consideration in the preoperative period, what we have to do in the preoperative period, how do we need to examine the patient, while we don't know the status of the patient, whether is it positive or negative for COVID. So in these conditions, we suggest that all the patients in the preoperative setup should be examined in a full protection. That means that the doctors and the nurses should be having full PPE. That means the N95 mask, respirator, goggles, face shield, gowns, double layer gloves, foot and head protectors. In the intraoperative consideration, we use full protection if we don't know the status of the patient. If the status is negative, then it's a different case, but if we don't know the status of the patient and we can't determine the status of the patient in a very short period of time, because PCR takes some 3 to 4 hours, and sometimes. And I just want to share with you, we lost one resident of cardiology, the department of Abdul Rashid, brother Abdul Rashid. He was finally a resident in Lahore in cardiology, and he developed a perforated duodenal ulcer, and he was delayed because of the COVID results, because of his investigation, and ultimately developed sepsis. When he was operated, actually we couldn't save. So this is because we can't delay these procedures to wait for the results of the PCR and results of the other investigation to determine whether he is COVID positive. So therefore, during the operation or intraoperative, we need to take certain measures as well. And at the same time, handling these patients in the post-operative period is also very important. The emergencies which we can see in the case of in an emergency room related to surgical surgery, these are the acute traumas. I discussed one of the acute trauma with you, the cardiothoracic traumas, cardiac tamponade, acute airway obstruction, pneumothorax. Then we have a gastrointestinal cases like acute appendicitis, complicated or uncomplicated acute appendicitis, small or large bowel obstruction, gastrointestinal perforation, intestinal valves, acute mesenteric ischemia, peritonitis, and the perforations of hollow viscus. In genitourinary, we might be having obstructed or strangulated hernia, testicular torsions, urinary retention in elderly people and even in young people, paraphimosis and priapism. In gynae ops, apart from the delivery, abdominal delivery or vaginal delivery, we have a bleeding ectopic pregnancy, retained abortions. And in neurological and ophthalmological cases, we might have acute subdural hematoma or retinal detachment. In vascular, we have a ruptured aortic aneurysm, aortic dissection, and limb ischemia. These are the cases which we actually receive in Shifa International Hospital, in Tertiary Care Hospital in our I'm just going through quickly through some of the specific cases. Just for example, acute hemorrhage. Majority of these cases, acute hemorrhage or the thrombosed hemorrhage, can be managed conservatively. But in severe cases, the surgical undertaking might be required. But in the case of perineal abscess, you don't have anything else other than taking the patient to operating room and operating. Soft tissue infection and abscesses are in another emergency. Acute pancreatitis. The majority of the time, acute pancreatitis is because of the gallstone. But the number of autoimmune pancreatitis is increasing, particularly during the COVID period. We have seen that in the past, this acute pancreatitis used to call idiopathic pancreatitis. Now we label it the acute autoimmune pancreatitis. We don't know what is the reason, but in the recent past 3 to 4 months, we observe the increased number of acute pancreatitis during this period. Majority of these patients, they don't need any surgical procedures unless there is a necrosis of the pancreas. Then we have a pneumoperitoneum or the gas under the diaphragm. What we have to do for that, and in tertiary care setup, majority of the time we go and insert a laparoscope and see and try to close the intestinal perforation by a laparoscope. But as you know, the aerosols are the major source of spread of infection, not only among the medics, but in the operating area as well. And therefore, we avoid doing majority of the time the laparoscopic procedures as well. It has been shown over the period of time, the uncomplicated appendicitis, they are being managed by conservatively. So not only in the COVID period, but otherwise as well, the majority of these patients, more than 60%, 70% of these patients, they recover on antibiotic treatment while they are uncomplicated. But complicated, like perforation, like the abscess formation, or like the peritonitis, these patients, they need surgical procedure under precaution. Symptomatic cholelithiasis. In other case, they can be managed conservatively as say, elective case, but sometimes these patients, they complicate. If the stone slips down and block the CBD, then we need to do something, and majority of these patients are treated again by the ERCP. But sometimes they need something else to be done, and especially if these patients that develop acute cholecystitis and abscess formation are empyema of the gallbladder, they preferably they should be treated by the the IR department, that is the interventional radiology department. If you insert a tube in the gallbladder and take by some time so the patient, so that the patient should be covered of that, and later on you can do it as an elective procedure. But some people, they might develop cholangitis and they need an ERCP as well. Diverticulitis is another disease which requires conservative management initially, but if they develop a paracolic abscess, that should be also drained, and we develop a procedure over the period of time under this under the fluoroscopic control or under CT guided. We can always do the drainage through interventional radiology procedure rather than going and opening these patients and causing more trauma to these patients. The vascular emergencies, leaking abdominal aortic aneurysm absolutely need a surgical procedure, and we don't have any other chance. Rest pain, yes, they should be treated mainly by endovascular procedure, but sometimes endovascular procedure doesn't work, and then you need to do an open procedure. Diabetic foot, they need extreme care. They need debridement, early debridement, and to save the limb, we need to do surgical procedure. Acute limb ischemia, thromboembolic disease, or trauma, as I discussed with you, majority of the time they need intervention, and that should be taken. So how we take the intervention? These intervention in Pakistan, in our setup, we do all these procedure in a negative pressure operating rooms area, and preferably in all those patients who are coming in emergency and we don't know the status, or we know the status is positive. That means the COVID positive patient, they need negative pressure operating room if it is available. If not available, then you can dedicate 1 or 2 rooms for these procedures, and they should not be used for the normal procedure. Other things, minimize the number of equipment in that area where you are operating COVID patients. Only the required instrument should be placed in that area, and those should be kept closed at all times during the procedure, so that there should be no exposure to the outside, and there should be a special protocol that you need to at least have 3-stage barrier. So the first barrier, you enter into the operating room after changing, and then the second barrier when you enter actually into the operating area. So all these measures should be taken in the in that particular area, and we need to have a PPE, specific PPE in that area to protect the medics as well as the other staff from the spread of infection. The full sleeve gowns with the cap, we use hazmat suit here with the full sleeve gown, then use the sterile disposable gown on the top of it. N95 masks are FFP3 use of surgical mask over N95. Protective goggles should be used, face shield, waterproof shoes, covers, long boots if possible, and sterile disposable waterproof gowns are used for the surgical procedure. And naturally, we need to have disposable gloves as well. So these are the few important things. And we need to minimize the number of staff as well. So anesthesia scrub nurse, circulating nurse, and housekeeping nurse are only enough in that area. And the number should be kept at minimum, and they should be pre-designed. We should be having level for every procedure, level staff for these patients. So some of the important reminder which I just want to share with you is the disposable surgical drapes will be used for all procedure. We should not reuse these linens. Maintain supply of the proper personal protective equipment. So we need to have a proper supply of the PPE as well. Dedicated equipment, anesthetic machines, and the carts and trolleys should be there for these patients. Detailed education of the operating room staff, infection prevention strategies, including frequent reminder. Define the role and responsibility of each and every member of the team. Runners should be outside the OR area. Utilize and mobilize the telephone. Telephone should be preferably all the telephone should be having a speaker added rather than using the handset. Transfer of the patient to the designated access area. Route should be designed, and that route should be cleared up before you trying to transfer this patient to the COVID ward. Waste management is another important area. All this disposable from this area should be disposed in a specific manner, wrapped in a yellow wrapper, and should go for incineration. Preoperative staff again need special safe surgery and surgical protocol. After handovering the patient to the next facility, they should directly go and change again. So it is important that all the patients should wear masks in these areas. Intraoperative care, I discussed with you. Post-operatively, these patients are usually observed in the post-operative area or in the critical area. Wherever they are being observed, they are being assigned the special beds and the area should be designed for these patients to avoid the spread of the infection to the other area. So the procedures which you do should these procedure rooms should not be mixed with the other. Very important that it should be a designated area and should be fumigated by after every single procedure. So it is a very cumbersome exercise, but we practice in Pakistan and it is working very well. Otherwise, there is a rapid spread of infection from one area to another area, and that could be determined. We should educate our housekeeping staff. There should be dedicated housekeeping staff fully protected with PPE. All the items that are used during the procedure will be disposed of in a biodegradable container as well. And this we use yellow bag here. And all the waste should be incinerated. Instruments, those instruments which are reused, they should be properly washed and then they are being sent to CCD department. Shops should be taken care very carefully. Anesthesia. Now the anesthetists nowadays in Pakistan, for example, the anesthesia department, they developed special protocol for the induction of the patient who are suspected for COVID or who are positive COVID patients. They need special precautions when they induct them because they are directly working on the upper airway, and that's a major source of infection. And therefore, these patients, they need these workers, whether medics or paramedics, they need a special care, and they develop a special policies for that. These policies are all these patients may require a surgical intervention or procedure should be screened if possible. If not possible to screen, they should be taken as positive. Number two, all patients who have COVID positive are suspected are waiting result and require emergency surgery should be operated in the designated area, that is a negative pressure operating room area. The sampling for COVID may be carried out before the procedure, but the patient should not be delayed because if the results are being delayed. The transfer should be carried out by the OR team itself rather than by the ward team. Sorry. Then we have some post-procedure. The patient should be recovered inside the same area. It should not be transferred to the post-operative area where normally we recover the patient. It should be recovered within the operating room. So the patient should be fully recovered in the operating room and then should be transferred to that area. And most importantly, the same procedure should be followed for all patients requiring intervention in other areas as well. Okay, this flow chart we have developed over the period of time. This is for our hospital, but I think it is a universal flow chart, and I'll paste it for you, that all those patients requiring surgical procedure in emergency, whether they are COVID positive or they are suspected positive, what they need. They need the PCR testing prior to surgical procedure. It takes about 2 to 3 minutes to take the sample and send it to the, and don't wait for the results. But if you can wait for the result for some time, and the patient can afford without any impending complication, then you can wait for them. Admit the patient, always admit these patients to the red zone area, that area which is designated for the COVID positive area. So all these patients should go to the red zone unless the results come out, and they should be isolated from very beginning. Once the result come negative, they can be operated as a usual procedure in a usual manner in a non-COVID operating room. But if the test comes positive, they should be taken. If they actually require to operative procedure, they should be taken to the negative pressure area. So these are the few things which I just wanted to share with you, and I think we should all take the important protective measure, because Allah subhanahu wa ta'ala says in Quran, وَلَا تَلْقُوا بِأَيْدِيكُمْ إِلَى التَّهْلُكَةِ وَأَحْسِنُوا إِنَّ اللَّهَ يُحِبُّ الْمُحْسِنِينَ. And don't kill yourself with your own hands, and do the best as Allah subhanahu wa ta'ala likes the excellence in the life. Thank you very much. If you have a question, I'll take later on. I think I am in time.
Thank you very much. Thank you very much, Professor Iqbal Khan, for your presentations. And before we continue to the next presenter, I would like to welcome all the participants here, some of the deans from medical faculty in Indonesia, and also members of FOKI and Indonesian Islamic Medical Association as well. Okay, since Professor Iqbal, would you like to wait for a moment, and then we will make questions at the end of the session?
Whatever your manual is, whatever you like.
Thank you very much. Thank you very much, Professor Iqbal. Okay, we will. Thank you very much. Okay, we will continue to the next speaker, Dr. Edward Panduwiryansyah. He is a pulmonologist consultant from Medical Faculty of Universitas Muslim Indonesia, Makassar. And the title is The Experience in Clinical Management of COVID-19 Patients in Makassar, South Sulawesi. Okay, Dr. Edward is already here with us, and I hope that the committee will. Okay, now Dr. Edward, the presentation time is for you now.
Thank you, Dr. Sulhana. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Bismillahirrahmanirrahim. Thank you for the opportunity. I would like to presenting my my experience about management COVID-19 in South Sulawesi, especially in Makassar city. For introduction, SARS-CoV-2, as we know that coronavirus causing current pandemic is ongoing viral replication in the body that can be detected in asymptomatic persons, pre-symptomatic persons, symptomatic persons, and post-symptomatic persons. COVID-19 is the disease caused by infection with SARS-CoV-2, which can vary in severity In mild, usually no need for inpatient care. Moderate, requires admission for care and typically present as pneumonia. And severe requires intensive care and typically includes respiratory failure. This is a statistic of COVID-19 in Indonesia. We got so many patient positive, 80,000 case, and from Sulawesi, South Sulawesi, we got 7,000 case positive, and in Makassar, we got 40,000 total positive. Suspect case definition: a patient with acute respiratory illness, fever, and at least one symptom of respiratory disease, and one of the following: a history of travel to or residence in local reporting community transmission of SARS-CoV-2, or contact with confirmed or probable SARS-CoV-2 infected, or requires hospitalization with no alternative diagnosis that fully explain the clinical presentation. There are three case definition. Suspect case are individual with upper respiratory tract infection and travel history to local transmission area, and individual with symptom with URTI, or with individual with severe URTI or severe pneumonia. Confirmed case is patient with or without symptom and positive PCR result. Probable case, suspect case with severe URTI, ERDS, died with clinical manifestation according to COVID-19 and no result of PCR test with any reason. In Makassar, so many symptoms, mostly patient come to hospital with complaint fever, cough, shortness of breath, cephalgia, myalgia, anosmia, hypogeusia, dysphagia, and gastrointestinal disorder like vomiting or diarrhea. Supporting examination, we can check radiology, thorax X-ray. It shows pneumonia, and CT scan of thorax shows ground glass opacity. Complete peripheral blood, we found leukopenia or normal, lymphopenia, monocytosis, and gold standard to diagnose COVID-19, we can check real-time PCR from throat swab, sputum, or bronchoalveolar lavage. This is image from thorax X-ray. We have pneumonia in lung, and CT scan of thorax is show ground glass opacity. How to management patient confirm COVID-19? Patient with asymptomatic, we suggest self-isolation at home for 40 days, educate them on what to do, give them leaflet to take home, vitamin C for 40 days, and patient check body temperature twice a day, morning and night time. Patient are monitoring by telephone by first level health facility officer and control after 40 days for clinical monitoring. Patient with mild symptoms is for self-isolation at home for 40 days, educate them on what to do, give an leaflet to take home, give vitamin C for 40 days, and we treat with chloroquine phosphate or hydroxychloroquine for 5 days, and we give azithromycin with alternative antibiotic levofloxacin for 5 days. And We can treat symptomatic, like if fever, give paracetamol. If needed, can be given antivirus, oseltamivir, favipiravir, and control after 40 days for clinical monitoring. Patient with moderate symptom refer to hospital, such Wisma Atlet, or in Jakarta, in Makassar, we such as hospital like Wahidin Hospital, Universitas Hasanuddin Hospital, and etc. Isolation in his hospital or emergency hospital, such 40 days, and give vitamin C, give chloroquine phosphate, hydroxychloroquine, and azithromycin with alternative levofloxacin, antivirus, oseltamivir or favipiravir, loading dose, and symptomatic. Patient with severe symptom, isolation in referred hospital isolation room, COVID-19 medication regimen, we can give same from moderate, it's like chloroquine phosphate, hydroxychloroquine, azithromycin, antivirus, oseltamivir or favipiravir, vitamin C, other supportive medication, exciting comorbid treatment, and monitoring closely. In general, WHO does not recommend giving steroid to patients with COVID-19, but recovery study, dexamethasone decreased mortality in critical ill patient by ventilator. Dexamethasone is not beneficial in patients with COVID-19 with mild symptom. Steroids are not for prevention. Management for unconfirmed COVID-19 patient, all patients under surveillance, moderate and severe symptoms are given the same treatment as confirmed case until proven not COVID-19. Special attention for children, the dose should be adjusted. Vitamin C given with maximum dose. If oseltamivir or favipiravir are not available, we can use lopinavir and ritonavir combination, and but favipiravir can be given to pregnant woman or planning a pregnancy. Patient with cardiovascular comorbid need explanation regarding the indication and side effect that occur due to the administration of azithromycin and chloroquine phosphate together. Azithromycin and chloroquine phosphate can cause bronchitis, so we must serial ECG examination is required. The administration of chloroquine phosphate or hydroxychloroquine is not recommended for patient 50 years, critical patient, instead of shock and arrhythmia. With patient pediatric with severe critical condition, chloroquine phosphate administration must be with special monitoring and consideration. Patients are declared cured if clinical improvement or throat swab PCR is negative 2 times in row in an interval of 24 hours. The patient is discharged when the patient has been declared cured. Comorbid are resolved and stable. Patients are educated on self-isolation at home for the next 40 days. But criteria WHO discharging patient for symptomatic patient is 10 days after symptom onset plus at least 3 additional days without symptom. For asymptomatic case, 10 days after positive test for SARS-CoV-2. Prevention wash your hands with an alcohol-based sanitizer or with soap and water, and then keep a distance of at least 1 meter between yourself and anyone who cough or sneeze, and then try your best not to touch your eyes, your nose, and your mouth. Cover your mouth and your nose with your bent elbow or tissue when you cough. Seek medical attention if you have difficulty breathing and a high fever, and follow direction of your national or local health authorities. For case example, according to WHO criteria, if patient has symptom for 2 days, so patient can leave the isolation from room 30 days from the date the symptom first appears or the symptoms onset. If a patient has symptom for 40 days, so patient can leave the isolation 17 days from the date of first symptom onset. If a patient has symptom for 30 days, patient can leave the isolation room 33 days from the date of first symptom onset. Case 2, the patient come to hospital with chief complaint shortness of breath since 1 day prior to admission. There are cough, fever since 3 days prior to admission. We found physical examination, we found Ronchi. Laboratorium, we found leukocytosis, granulocytosis, and lipopenia, increasing CRP and saturasi oxygen 98% with oxygen nasal cannula. Swab throat PCR, we found positive SARS-CoV-2. Diagnose this patient COVID-19 confirmed. We suggest therapy with oxygen support, oseltamivir, azithromycin, vitamin C, N-acetylcysteine, and paracetamol. And swab control 2 weeks after therapy, we found negative. Thank you, Dr. Sulhana. Please.
Thank you. Thank you, Dr. Edward. Nice presentation as well. And again, we must keep the questions. But actually, in the chatting room, there is a question for Professor Iqbal. But please, Professor Iqbal, allow me to postpone the questions for you, and let me continue to the next speaker. Professor Iqbal, I hope that you still with us until the end of this seminar.
Till the end. I get lights, a lot of lights out of Sitaka, my brothers and sisters.
Thank you. Thank you very much, Professor Iqbal. Okay, then we going to the last speaker. Since Professor Hassan Guchlu is not able to present today, there is something happened in the faculty. So we will continue to the last speaker, Dr. Kusbaryanto MKes from Indonesia, Universitas Muhammadiyah Yogyakarta, Indonesia. And the title is COVID-19 Pandemic and Community Medicine, an Islamic Perspective. So to Dr. Kusbaryanto, okay, I will give
Okay.
I will give the room for you, Doctor. Please.
Yes. Thank you, Dr. Sulhana. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Yes, I want to present my presentation. The title is COVID-19 Pandemic in Islamic View. Next. I think in this religion we have 5 Maqasid Syariah, Islamic law objective. But in this case, in this topic, I think two kind relevant with this topic. The first is hifdudin, preserve religion, menjaga agama. Number two, hifdun nafs, preserve soul, preserve of nafs. I think two kind of maqasid syariah relevant with this topic. Next, and with kaidah usul fikih rule, I think three kind relevant with this topic. The first, adororu juzal, danger must be eliminated, bahaya itu harus dihilangkan. So this COVID-19 in this case must be eliminated. Number two, adoruratu tubihul mahdurat. American situation allow all previously prohibited matters. Jadi keadaan darurat itu membolehkan hal-hal yang terlarang. For both Friday prayer, substitute by Dhuhr prayer. Maybe Eid prayer or 5-time prayer. We do not in the mosque, but in our home, in our house. Number 3, darul mafasid muqaddamu ala jalbil masolih. Refuse mafadah dimit first before taking benefit. Jadi menolak mafsadah atau kerusakan itu lebih didahulukan jalbil masolih daripada menerima kebaikan. So we using mask, physical distancing, social distancing is application of darul mafasid muqaddamu ala jalbil masolih. So we must consistent with this prevention for COVID-19. Next. The plague of Ta'un during Umar bin Khattab era. Ta'un Amwas was the first Ta'un plague in Islamic history. It occurred in Caliphate of Umar bin Khattab in 18 Hijr. Happened in a city named Amwas. Next. To this Ta'un, many Prophet Muhammad SAW companion were the victims as Abu Baidah, Mu'ad bin Jabal, Yazid bin Abu Sufyan, Surah bin Hasanah, Abu Jandal bin Sahal bin Umar, and his father. And Fadl bin Al-Abbas bin Abdul Muttalib, Prophet's cousin, brother of Ibnu Abbas, may Allah bless them. Nah, di antara mereka adalah Ahlul Badar, peserta pengikut perang Badar. Yes, continue. This location of Amwas city. So this Amwas city, this Jerusalem. So Amwas city now in Palestine maybe. Yes. Next. At the time Ta'un Amwas occurred, Prophet companion was confused in overcoming the situation, since it was this first time in Islamic history. Prophet Muhammad SAW, who always become a place to ask when a problem occurred, was passed away a long time ago, and his companion, who might know the solution, had already spread to many Islamic countries from North Africa to China borders. Next. Different opinion emerged among Prophet companion. Half of them proclaim to move from Weblak was occurred to another place. Other proclaim such action was a form of running from Allah's will, and that with had been destined. Next. The most popular story regarding this issue was dialogue between Umar bin Khattab and Abu Ubaidah bin Al-Jarrah radhiyallahu anhuma. When Umar invited Abu Ubaidah to move from Ta'un place, Umar's invitation was answered by Abu Ubaidah. Oh yeah, Amir Mu'minin, do we want to run from Allah's will? Next. Umar answered, if only someone else would have said this other than you, Abu Ubaidah. Yes, we run from Allah's will to another Allah's will. This Umar statement is familiar to opinion about takdir Allah. What is your opinion when you have a camel and it stop for food in a valley with two sides? One of them is flourishing while the other is dry. If you got your camel in the flourishing side of the valley, don't you don't, you- don't you done it because of Allah will. Likewise, if you got your camel in the dry side of the valley, don't you done it Allah because of Allah will. Abu Ubaidah answered yes. Next. Nevertheless, Abu Ubaidah persistently refused Umar's invitation to move and preferred to stay in this place where the plague took place and until he died. At this time, he gathered his people and said, "O people, this plague is indeed a place for you. It is the prey of our prophet and the cause of many good people before you died. And actually, Abu Bakr plead to Allah to give me my turn to die as martyr due to this plague." Continue. Next. Not long after that, Abu Bakr died and his position as some leader was given to Mu'ad bin Jabal radhiyallahu anhu. After sit in his position, Mu'ad made a speech in front of his people and said the same like Abu Bakr. After that, his son Abdurrahman infected by Ta'un and died. No, not long after that, Mu'ad himself also get infected by Ta'un. Next. Umar bin Khattab step in. Umar bin Khattab turun tangan with this case. To the Ta'un Amwas ferocious outbreak, Caliphate Umar, who was in Medina, capital city of Islamic government at the time, lent a hand to Amwas in order to find solution to cure and stop the plague outbreak. The plague caused for about 30,000 dead. Others say 70,000 dead only in 3 days. Yes. Next. At the time, Muslims also deal with new problem about inheritance splitting, Farid and Mawarid, saying between someone who left inheritance and it have passed away almost at the same time. So it was unknown who was passed away first. Therefore, in this case, it had to apply general inheritance distribution. Kemudian timbul masalah mal waris ini, masalah warisan. Karena banyak sekali yang meninggal dalam waktu bersamaan. So next, clever isolation. Ini ada solusi yang bagus. Solution from Amr bin As. Ta'un Amwas that befell Muslim in Sham had not decreased and seemed like would not stop. Muslim at the time went through to Rhodes until a clever prophet companion, Amr bin As, governor of Egypt, came and gave solution. Amr bin As was famous because of his intelligence in solving problems. Even his intelligence was known since Jahiliyah era, age of ignorance. Next. After Mu'ad bin Jabal passed away and his position held by Amr bin As radhiyallahu anhum, Amr bin As gathered all of people and made a speech. Oh people, this plague indeed occurs like a flame. So protect yourself by dispatch to heal. Jadi warga masyarakat diminta untuk bergunung untuk menyelamatkan diri. Dispatch menyebar. Distance. Next. He means that the plague outbreak situation is like flame, seperti api. If flame does not get wood, it will goes out. That was the suggestion to all people to disperse at the corners of city for some time. Finally, due to Shah policy and with Allah's permission, town outbreak could be solved and the spread was stopped. Next. Now, COVID-19 punishment for health of people and blessed for faithful people. Condition in birth does not define success in Allah's sight. Suffer, poverty, sick, and so on does not mean Allah does not love us. Otherwise, health, wealth, and poison is not a benchmark of Allah loving someone. Benchmark in Allah's sight is iman and good deeds. Iman dan amal soleh. Someone whose Allah love may be given difficulty, poverty, disease, and so on. And this is most common condition of Prophet and Allah Messenger. Otherwise, people who are most despised by Allah may be given with wealth and power, for example, Fir'aun and Qarun. Next. Our Prophet informed that Ta'un is misfortune that Allah sent for the faithful people and others. Allah make the misfortune as punishment and fortune for those who Allah decided and bless for faithful people. Faithful people who infected by Ta'un and keep patient in facing it. They would get married. Some as those who died as martyr because fighting is Allah's path. Continue. Yes, next. Nah, Rasulullah say, in your opinion, who are included as martyr? The companion answer, Ya Rasulullah, martyr is those who died in Allah's path. Rasulullah answer, it is so, then martyr within my people are a few. His companion that then asks, then who are they, Rasulullah? Rasulullah answer, whoever killed in Allah's path is martyr. Whoever died in Allah's war is martyr. People in 2 tahun are martyr. People who die due to somat disease is martyr. And people who are thrown is martyr. Next. Rasulullah SAW said, Ta'un is shahadah for each Muslim. Hadis Bukhari from Anas bin Malik. Next. Is it as it is mentioned in Hadis Ta'un outbreak became? Allah mercy for faithful people by forgiving their sins a good place, give a good place in heaven to their patients in facing Allah will. Likewise, to people dead due to COVID outbreak, they may also get married as martyr in jihad way. Next. Sick and disaster in general are Allah mercy for faithful people. Many Quran say about that, especially this Ta'un outbreak. With sickness, Allah want to give merit of patience to His servant. And this merit of patience is different from other good deeds that still has number value. As mentioned by Allah, merit of patience is limitless. Allah said, firman Allah, say, O my servant who have believed, fear your Lord. For those who do good, and this word is good, and the earth of Allah is spacious. Indeed, the patient will be given the reward without account. Jadi kesabaran itu akan membawa pahala yang tanpa batas. Orang yang sabar karena penyakit di antara COVID mendapat pahala yang besar tanpa batas, without account. Next, prevention and treatment endeavors. Endeavor and treatment are Allah and His Messenger suggestion. There are many grounds either from Quran and Sunnah which suggest for us to seek for treatment. Among the solution to by prophet that people who are in the place for plague do not go out from the place, and vice versa for the people outside the place. Next, Allah said, firman Allah, there is no contagious disease spread without Allah permission. Not is there any bad omen from bird, not any hama, nor is there any bad omen in the mountain of Safar. And one soul run away from the leopard as one runs away from lion. So kita harus hati-hati terhadap penyakit dan menjaga diri. Terus, next. Ya, prevention of disease and other bad thing from our religion. The first, wash our hand and take our wudu. Properties, we are prohibited to put our hand in vessel before we wash our hands. Rasulullah said, when anyone among you wakes up from sleep, he should wash his hand 3 times for putting in the utensil. For he does not know where his hand was during the night. This is hadis riwayat Bukhari and Muslim. Next. Number 2, full oblation. Number 3, cutting nail, plucking armpit hair, trimming mustache, and shaving pubic hair. Next, number 4, cover all containers and vessel. This is this hadith. Next, close door and window when night come. Clean bed when going to sleep. Blow out flame and turn off the lights when you want to sleep. This is my presentation. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Kusbarianto. And I think your presentation is quite, the prevention from Islamic point of view quite resembles with the PPA, yes. And this is the end of our session. Okay, let me go to the audience. Whoever wants to ask any question, please raise your hand. And probably I would like to invite first the deans from medical faculty here in Indonesia, and also participants from CIMCO. If there is any questions to all the speakers. Okay, Professor Wawang.
Thank you very much. Yeah, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Can you hear my voice? Is it clear?
Yes, Professor, it's clear enough.
Okay, thank you very much, moderator. I would like to ask the speaker from Malaysia, also from Pakistan, how many doctors were died because of COVID-19 in Pakistan and in Malaysia, because here in Indonesia is a little bit high. And what is the reasons? What is the etiology of the die of the doctors? Because of the less precaution, or because of the hazmat, for example, and so on and so on. Thank you.
Thank you, Professor Wawang. Yes.
Is it clear, my question?
Yes, it's clear.
Okay. Thank you.
Maybe, yeah, since your questions is for Professor Iqbal and Professor Rashid, so maybe first I will invite Professor Rashid first to answer the questions. Okay, Professor Rashid. Okay. Next, I will move to Professor Iqbal Khan since Professor Rashid is quite not around here. Professor Iqbal, please unmute your voice.
Yeah.
Okay.
Thank you very much. Jazakumullah khairan. First of all, the last speaker. I really enjoyed the last speaker's presentation. It's a very good presentation. I request him to kindly forward it for the benefit of the people in Pakistan. Please forward this or email me this presentation for other people as well. Now, regarding the questions, which you put the mortality rate in general in Pakistan is around 2%. That means I can share with you very interesting figures that in Pakistan, more than 80% of the people they present the patients they present either with the moderate, mild or moderate cases of COVID. Only 15% people they present with moderate to severe, and only 5% of the people they present with the severe symptoms requiring intensive care and sometimes the critical care management as well. So the mortality is around 2%. Now you might be asking about the mortality among the medics. It's unfortunately the mortality in Pakistan among the senior medics is very high. Nearly 100 medics, they doctors and the paramedical staff, more than 100, they actually succumbed to life during this COVID period and due to COVID. Among those, there is a vice university as well. There's a president of the university, medical university, it's called Nishtar Medical University in Multan. He died only last week because of COVID. And there are few senior professors who died. Among those are the professor of ENT, professor of eye, professor of medicine, and also the professor of internal medicine. They died of the COVID. But rest of the people, they are from the, they all died due to while treating the patients in the COVID areas. So they are nearly 100 or 110. I don't know the exact figure, but until last week, they were nearly 100, and now probably in excess of 100 at this moment. The total number of patients in Pakistan are now declining. So, and as the medics are declining, the severity of the disease is also declining. I don't know this phenomena, but now we get less patient in ICU, less patient in critical area than in the past. We about 15 days back, our critical area was flooded with the patients, but we have now many reserve rooms and reserve beds available for the COVID patient lying vacant. So the things are under control now. This is the question. Have I answered the question, or you have some more question? I'm here to answer it.
Bagaimana Prof. Wawang?
Yeah. All of the medical and paramedical will die. Are they working at hospital or no? Are they working at hospital, or the doctors and all the
we only consider if they are working in the hospital. They are nearly 100, in excess of 100.
Yeah. I think that the mortality there, that it's more than in Indonesia, because Indonesia is about less than 50 or 60. Okay, thank you, Professor.
Thank you, Professor Wawang, for the questions. And we are moving to the next. The next question from Dr. Iwang Yusuf. Please, Dr. Iwang.
Okay, thank you.
To whom you would like to.
Yeah, I want to ask to Professor Iqbal. In my mind, if we we talk about management emergency in surgery, I think is so many critical sites, especially in ambulatory, in ER room, and operating room. So I want to know the Pakistan experience about that. This is a new habit in Indonesia for medical services. Is all the doctor or paramedic is use the safety clothes, level 3, and so on. What your the reason about that? Because in Indonesia, operating room is lack of negative pressure of room. What your reason about?
Thank you very much. Brother, we in particular in our hospital, we use the negative pressure rooms for the for taking care of those patients who are either suspect or confirmed positive COVID patients. We use negative pressure rooms, dedicated negative pressure rooms for the operation. The pre-operative area, we don't hold these patients in the pre-operative area, and we don't hold these patients in the post-operative area as well. They directly comes from the red zone or the COVID area to the operating room, and they are being they shifted from the operating room into the COVID area. So normally we don't have pre-operative hold up and the post-operative hold up of these patients in the operating area. And the places where we don't have, some of the hospitals in Pakistan, they don't have negative pressure area, as we were talking about. So here you can only dedicate few areas in the operating area where other operations should not be performed. This should be dedicated only for the COVID patients or the suspected COVID patients. So you can use 1 or 2 operating rooms for this particular purpose in a big hospital. But in a small hospital, it is sometimes difficult to maintain this ratio. If you have 4 operating rooms, then you can at least dedicate 1 operating room for the COVID patients, and depending upon the number of your patients as well. So if you get more patients, you can dedicate 2 rooms, but these rooms should be clean and fumigated after every surgical procedure. And these rooms should not be used for the elective procedures. In Pakistan, during the last 4 months, we abandoned the elective procedures. We only did the cancer surgeries and the very urgent required surgeries, which otherwise we don't have any other reasons to postpone. So therefore, we, for example, in our hospital, we have 24 operating rooms. So we easily dedicated 4 operating rooms for the COVID patients. But in other places, depending upon the numbers, you can allocate few resources for the COVID patients. As far as the transfer of these patients is concerned, there should be safe transfer. There's a written protocol how these patients, I can share with you all these protocols, how these patients are being transferred. They are being transferred by the special escort of the COVID area. They are not being transferred by the usual people. So they are transferred in the specific channel, in the specific route, and in the specific the escort of the escort team as well. So therefore, we take utmost care, but still, you know, there is a chance of spread of infection, but we need to minimize this chance as far as it is possible. Hope your answer.
Okay. Thank you, Professor Iqbal. How about that, Dr. Iwang?
Yes. One more about how we know the emergency patient is a COVID infection or not.
Sorry, Yusuf, can you repeat?
Okay. In emergency patient, how we know that the patient is infection of COVID or not COVID?
Okay. Thank you very much, brother. Give me 1 minute to explain everything. In emergency department, our ER rooms, we have got a big emergency comprising of 50 beds. So we dedicated few rooms for the red area for those patients. Now, your question is pertinent. You ask how we know. So those patients who have symptoms, so they come directly to that covered area and they are being screened for that. But those patients who are coming only for the outpatient emergency, that means they don't need admission, we dispose them off from that area quickly without admitting them in the hospital. And they are being examined with full protection. Those medics and paramedics who are dealing with these patients, they are fully protected with PPE. If these patients, they need admission, then they need to test either their PCR or their HRCT of the chest. So if they do chest CT and we suspect, we do PCR, and then we admit these patients in the emergency. They need emergency care and they go to red zone in the hospital, indoor hospital, until and unless their tests become negative, or their chest CT is negative and they are symptom free. These patients can be operated in the usual operating rooms. Hope I cleared that.
Okay, thank you, Professor Iqbal. How about that, Dr. Iwang? Hello, Dr. Iwang?
Assalamualaikum.
Oke. Panitia unmute punya saya, jadi saya bingung. Oke. Thank you, Professor.
Seminar में थोड़ी देर बाद ना.
Professor is here.
Okay, we will continue to the next questions from the audience here. And yes, there is a question to deliver almost the same question from Professor Wawang has just now asked to Professor Iqbal, and the same question is asked to Professor Rashid as well. And as you can, it's about the mortality rate of COVID-19 in Malaysia that is very low compared to Indonesia. So we want to know what is what was the policy that you do there, and how about the medical staff there? What are they doing there to compare to an Indonesian medical profession that we have quite a high presentation of mortality rate. This is to compare to Malaysian case. Please, Professor Rashid, would you like to respond to the question from Professor Wawang?
Please unmute.
Oh.
Yeah, okay. Assalamualaikum.
Waalaikumsalam warahmatullah.
Sorry, I'm using my wife's computer, so her name was.
Oh, yes.
Okay, Alhamdulillah, as I told you just now, when the COVID epidemic starts in Southeast Asia, we have the largest number. Now we have the lowest number.
Yes.
Basically, as I mentioned just now, in Malaysia, we have a central command by the government. The Ministry of Health is in full control of everything to do with COVID. For example, only government hospital and only 2 out of the many teaching hospitals can manage COVID. Very, very clear. At the district level, the SOP is very clear. If you have a patient you suspect with COVID symptoms, you do a triage, and these are all standard protocol used all over the country. You use a triage system, and if you think the patient is under investigation, you send to government facility. In other words, the approach is very systematic. Not anybody can diagnose COVID and treat COVID. That's point number one. Point number two, I think the biggest difference is that when we implement our lockdown, we really implement our lockdown. People who do not abide to the lockdown, we call it movement control order, they are punished. Not physically, like some video you see from India, but they are punished financially. Even deputy ministers were fined. Even the ex-deputy prime minister's daughter was fined if they break the law in terms of movement control order. Almost everybody follow what the government said, and alhamdulillah, we are not a big country, unlike Indonesia, so we can contain and we can actually monitor things very closely. Every day at 5 o'clock, the Director General of Health will organize a press conference and update the country about everything you need to know about COVID, including new cases, new clusters, and patients. Once they have been diagnosed, there is intensive contact tracing, and the protocol of treatment is very standardized. And in Malaysia, we try to be as evidence-based as possible. For example, when I saw a presentation from the third speaker, many of the things which he mentioned, in Malaysia, if it is not proven by clinical trials, we tend not to do it. For example, patients who are moderate symptomatic and whatnot, we don't give them chloroquine or azithromycin because there's no evidence from randomized control trial. We do give them some antiviral only in certain centers only, in infectious disease center. So all these things helps a lot in us combating the epidemic. Now for private hospital, every hospital have got a very strict triage system. In my hospital, we see patients outside the building of the hospital. We have a strict, stringent system. We have a patient are asked to fill in a QR form before they come, and if there is any warning, there's any red light or red flag, sorry, then we will not admit them to the hospital. We will advise them if they are well. If they are well, we ask them to do what we call either a testing in the emergency department, or we ask them to come back to do a drive-through. Drive-through test is very popular in Malaysia. For example, we did hundreds and hundreds of drive-through in our hospital. And if they are not very well, and we suspect that they've got high risk of COVID, for example, history of contacts and things like that, we send them to government facilities for testing. We send them to government facilities. Any patient who have a fever, any patient who we suspect may turn out to be, any patient with a fever, febrile illness, we send them in our hospital to a dedicated ward. It's called the isolation declared ward. And the isolation declared ward have got negative pressure and is approved by the Ministry of Health. We keep them, we test them. If they are positive, we send them to the Ministry of Health, and the Ministry of Health will come with their own ambulance, like Dr. Iqbal said, with a strict protocol. Any patient who are due for surgery, even elective surgery, more so elective surgery, all mothers who's going to be delivering, pregnant woman, any fever, we send them to the isolation declared ward. Any cardiology patient who needs intervention, catheterization, we send them to the isolation declared ward. We swab them first. If they are negative, only we do the procedure. In emergency cases, we have dedicated labor room, dedicated OT, where if they have to be operated, then we operate them. We keep them in the isolation declared ward. And if they're negative, we send them to the normal ward. If they are positive, we send them to the government facilities, and we, of course, sanitize and also, just basically clean the whole place. So it's very the word is very directed. It is very controlled by the Ministry of Health, and in terms of care, because we try to adopt a standardized protocol. Alhamdulillah, our mortality rate is only 1.4%. which is very good, alhamdulillah.
Yes.
And so far, as you probably know, we are probably over the worst now. The country is opening up, and on the 31st of this month, we can go back to almost everything we have done in the past. Now we can do almost 90% of what we do in the past. And inshallah, end of this month, we will get hopefully back to almost normal. But with a very strong reminder, if there's any more outbreak, we will go back to where we started. And we have discovered new clusters, but they're very small cluster. Most of the new clusters are imported cases, a Malaysian student coming back from overseas. But very quickly, we contain them, we isolate them, we contact trace them, and we manage them with a standardized protocol. And all of these things, and alhamdulillah, because being a small country, we can manage it. Small country and small population. I know it's going to be difficult in places like Indonesia or Pakistan, but I think if you start on the right footing and you follow a standardized approach, and everybody is vigilant, and you suspect them, trace them, test them, trace them, and do tracing, and then treat them systematically, inshallah. I think we managed to get on top of the COVID so far, alhamdulillah.
Thank you, Professor Abdul Rashid. I guess that's the point is from your answer is that this is the government should help take care.
Very much, very much.
May I interrupt?
Yes, okay, Professor Wawang.
Okay, thank you, Professor Iqbal. Yeah, the problem
Professor
is
Rashid, yes.
Professor Rashid. Okay, sorry. You know, we have also the rule and regulations for how to manage the COVID-19. Also, we have, for example, drive-through for examine the blood and something like that. But the problem for us is because our people is spread out in 17,000 islands. You know, it's not easy, and we have the population are about 262 million. That's the problem for us. The case fatality rate in Indonesia is about 4.6 now. Beg your pardon, what is the case fatality rate in Malaysia?
1.4%.
1.2 is very low, yeah.
1.4, 1.39,
1.4, yeah, because but it did also decrease because before the case fatality rate is about 6.6, 8.6 or 9.4, but now it's decreased. It's about 4.6. It's
okay.
We hope that will decrease gradually until August or September. Thank you, Professor Rashid.
I think the problem sometimes in some countries, the leadership send mixed messages.
Yes.
Just like Donald Trump, just like Bolsonaro. When leaders send mixed messages, the public becomes very sure there is no mixed messages. If anything, the public tell the government they are not doing enough sometimes.
Yeah, because human rights in America is like that, you know. It's crazy. Yeah. Thank you, Professor Rashid.
Welcome.
Thank you, Professor.
Boleh saya tanya yang lainnya, Pak, Ibu?
Oh iya, iya Dok, silakan Dok, silakan Prof.
Sultana.
Iya, ada Dokter Kusbaryanto.
Boleh saya tanya ke yang lain?
Boleh Prof. Ada Dokter Kusbaryanto dan Dokter. Ya, boleh Prof. Ada Dokter Kusbaryanto dan Dokter Edward.
Putus-putus ya?
Oh maaf Dok, saya dengar jelas suaranya Dokter.
Oke lah, nanti lagi. Putus-putus kelihatannya.
Silakan Dok, silakan Prof. Kalau mau bertanya lagi ke narasumber, ke speaker yang lain. Prof. Wawang. Okay. It looks that Prof. Wawang, yes, quite got the Dr. Iwang, probably you want to ask a question to. I thought that you want to ask a question to Professor Rashid.
Yes.
Yeah, assalamualaikum. Waalaikumsalam warahmatullah.
I heckled your statement in the end because about is inhibitor and ARB.
Yeah.
Must go so on. Must go.
Must continue. Yeah.
Yeah, must continue because possibility
Yeah.
is to is a benefit for going to COVID-19 did not enter the cell pneumonia type 2.
Yeah.
What your reason about that? Because H2 is the enzyme to convert angiotensin 2 to be angiotensin 1 to 7, and they can burn the ATR2 and the increasing anti-inflammatory, fibrosis, and so on.
True. True.
Yes.
True. Yeah, this is what I call you know, every time you got a new disease, you understand the pathogenesis first. And in COVID, one of the things we understand about the cytokine storm, and also the fact that the virus enters cell through ACE2 receptor affinity. So because of that, people starts to theorize or hypothesize. So this is where in medicine we have biomechanical mechanism or pathogenesis, and we also have clinical trials which will prove it either way. So based initially in January, February, on on studies ex vivo or in vitro, we know that the virus needs to enter the cell through ACE2 enzyme, receptor. And once it enters the cell, it will take over the cell function, like most RNA virus will do. So that creates worry that, if you got more ACE2 receptor, the virus will have a nice time to enter your cells in your body. However, even in January and February, all the expert society in hypertension and cardiology agree unanimously that this is a theory. It is not proven by any clinical trials. At the moment, of course, we cannot do trial. It was still early. All the society, American, European, even in Malaysia, we mentioned, do not worry about this. This is theory. Do not stop your patient medication, because ACE inhibitor, especially an ARB to some extent, is life-saving. In cardiovascular disease, it has been shown in many, many trials, in heart failure, in diabetic, in hypertension, in CKD, to be life-saving. So do not stop medicine based on theory. You use medicine based on evidence from randomized controlled trial. So that's point number one. Point number two, alhamdulillah, as early as April, you already have observational study from case series from China to show that patients on this treatment actually are not more harmful. The outcome is no difference from patient not in this treatment. And the studies which came last month, I showed you two studies to show that if anything, they are doing better than patients who are not taking this drug. So there you are. Clinical decision can only be based on good research, not on biomedical understanding of pathogenesis disease. Not everything in medicine fits what the theory say. This is a very good example. But I also finished my talk by saying that, again, this data, which I quoted from China, published in Lancet, published in Circulation Research, published in European Heart Journal, all are top journals in medicine, not just in cardiology. These studies show that based on observational study, it is safe. In fact, they do better if they're taking this drug. But that is not the finished item. That is not the conclusive evidence. The conclusive evidence will be from randomized controlled trial. And I give you 3 trials which are being conducted. One of them is finished, and it will be presented in Amsterdam end of next month in the European Society of Cardiology. So that's how we move in medicine, based on theory, then we do observational study, then we do randomized controlled trial. My advice to colleagues in Pakistan and Indonesia, because you got many cases, you see, you must write up your experience. Most of the articles are from China. They wrote their experience very, very fast. In Malaysia, we only had 8,000 cases. All the cases are being collected by the Ministry of Health. They are going to publish it. 8,000 over cases, and the National Institute of Health will publish it. And I hope that all our FEMA affiliate country can collect all our data and study publish basic things. In Makassar, you got 2,000 over cases. Publish them. First, observational data, descriptive data. And then if you have time, you've got more cases, then you can even do randomized control trial. Wallahu a'lam.
Thank you, Professor Rashid. I guess, how about that, Dr. Iwan? I guess
Yes,
that's...
clear from Prof. Rashid, but I want to ask Dr. Edward and Dr. Kusbarianto.
Okay, Doc, please.
Yes.
Saya juga ke Dr. Kusbarianto ya. Saya juga nanti ke Dr. Kusbarianto.
Ya, ya, Dok. Ya, Prof. Ya.
Tadi menghilang, tadi hujan besar di sini.
Ya, Prof. Iya.
There is a big raining in Bandung because I'm now in Bandung. Oke.
Bawang dulu aja.
Ya,
Bawang,
terima kasih. Yang muda harus mengalah ya. Thank you very much, Dr. Iwan. Dr. Kusbarianto, I would like to know how long the disease in Taun disappears at that time.
Dr. Kus, can
Dr.
you hear
Kus,
the...
how long the disease in Taun was disappeared at that time?
Okay, Dr. Kusbarianto, can you hear the questions from Professor Wawan? Please unmute your audio, please, Dr. Kusbarianto.
Yes, thank you. From my reference, the victim for about 30,000, ada yang berpendapat lain itu 10,000 yang meninggal. Only 3 days, so very fast. Only 3 days.
3 days, Doc?
Yes, only 3 days. Please, you see my presentation. Yes.
Oh, I'm sorry, I missed the presentation.
Only 3 days, so very fast. Yes. This is my answer, Dr. Wawang.
Okay, Prof. Wawang, itu jawaban dari Dr. Kus. He said that only in 3 days the contagious running and caused thousands of deaths.
Bagaimana bisa? How can do that at that time? Because traditional management but it's very fast, 3 days only.
Yes.
Barangkali tahu, kenapa bisa kayak gitu. Kan bisa ditiru. We can follow that treatment maybe.
Oh ya.
Wawan.
Ya.
Itu kan berganti pemerintahan. Lama itu karena berganti pemerintahan.
Iya. Ya, setelah diganti oleh
datang baru.
Ya, pemerintahan baru Amr bin As.
Iya, lama.
So, Amr bin As memerintahkan
3 hari.
Ya, untuk lari disperse to the hill, lari ke bukit-bukit semuanya.
Ya, betul.
Namanya social distancing.
Ya, lari ada yang tinggal di bukit, ada yang keluar, tidak boleh masuk dan seterusnya.
Dan
habis 3 days ya.
Ya, udah 3 days. Dan this policy is relevant with Umar bin Khattab opinion of takdir. Yes.
Yeah, and that's why if we can implement it, social distancing, for example, in 2 weeks or very easy, I think the disease will disappear. I'm sure. But the problem is the discipline of the peoples.
Yes.
Yeah. Okay. Thank you.
Yes.
Thank you, Professor Wawang. Okay. I would move to another participant who would like to ask for. Probably this is the last question because we are going to the end of our session here. Actually, there is a question from one participant, and it looks that he gives the question to all the speakers. He said that he asked that on the newly issued criteria of WHO, is it true that no swab control is needed after the patient has no symptoms at all? Is it immediately cured? Please, your opinion. Who wants to ask the question first, please? Probably I will deliver this question to Dr. Edo. Dr. Edward, sorry, Dr. Edward. How do you think about this?
Yes, considering longer contagious, several studies state that patient with has no symptom
Yes.
pre 10 days no long to transmit it anymore. So some studies says like that. One studies I read SUI studies. She say that patient with no symptom is free or not no long to transmit it for another people.
Okay, so that's the answer, Dr. Edward. Probably the speakers, the rest of the speakers, do you have any opinion about that? The question is about the swab control that, yeah. Someone said that the WHO has released a criteria about swab control that it's not needed to do the swab control when the patient has no symptoms. How do you think about that, Professor? We start from Professor Iqbal, probably. Would you like to answer that? Professor Iqbal, okay.
I couldn't get the questions. Can you repeat the question?
Okay. This is according to the participant here asking about the newly issued criteria from WHO. Is it true that no swab control is needed after the patient has no symptoms? Please give us your opinion about that.
Yes, WHO says that after 10 days after the your symptoms are finished or you have concluded with the symptoms, you don't need to be retested or re-swabbed for the COVID. But if this patient is going for surgical procedure, probably you need to wait for 3 weeks. Either you wait for 3 weeks or you do a swab test so that it should be negative. No, this patient should be false positive as well, because the destroyed proteins are circulating in the body, and therefore you take the swab, it will become false positive. This is the only case where you get the false positive PCR results. Now, it's previously about 4 weeks back, we used to do antibody tests, serology tests for these patients. If the serology comes strongly positive, then we consider that these patients are safe to be operated. But now we wait for 3 weeks. Now the new protocols are for the procedure, for the electrosurgical procedure is you wait for 3 weeks, and after 3 weeks, this patient can be safely operated. PCR test, if you do it, becomes positive if the patient is symptom free. Now, secondly, the patient who is not going for surgery, he is just a COVID patient. After 2 weeks, you don't need to do any PCR test. This patient is not dangerous for the society, for the other people. He is not going to transmit the disease if he has a symptom. Thirdly, the patient who is going for those patients who are medics, then they need to come back to work after 3 weeks. Now, in the WHO protocols are that they should come back on work after 3 weeks, and they also do their PCR test. If the PCR test is negative, he can join even after 2 weeks. But if the PCR becomes negative, you wait for 3 weeks. If the patient is symptom free, he can join his duty as a medics or paramedics in the hospital setup or in the other healthcare facility setup without any posing danger to the surroundings or to other people.
Okay, thank you, Professor Iqbal. And I'm going to move to Professor Abdul Rashid. Do you hear the questions?
Yeah, I do.
Professor? Yes, please,
Okay, a
your
patient
opinion.
once positive, they will go to government facilities. They are treated accordingly, whether they are asymptomatic or mild symptom or severe symptom. Then once they completed their treatment, they will be swabbed. When we were at the peak of the COVID epidemic in Malaysia, we do 2 swab. Patients are now asymptomatic. They have to do 2 swab. Both swab must be negative before they are discharged. But now only 1 swab is enough, provided they are, of course, asymptomatic. Again, this is in keeping with the WHO recommendation. Again, Alhamdulillah, Malaysia is lucky, not too many cases, so we can afford to do a second swab. Even for a patient who just come, for example, I got a patient the other day, just came back from Singapore, no symptom, first swab negative, second swab to be taken after 14 days, because we are not pressure for too many testing to be done. Patient for surgery, again, if they're asymptomatic, after 14 days, we also want to do second swab for surgery. For example, most of our pregnant women in my hospital, they will be swabbed on the 37th week or the 38th week, because we noticed that most of the patient deliver either week 38 or week 40 or 41. So again, 2 weeks, we still use the 2 weeks formula for asymptomatic patient. For patients who are treated, either minor symptom, mild symptom, severe symptom, they must be over all the symptom clinically, and one is enough now, no longer 2. Alhamdulillah. The problem, of course, as you know, there are many asymptomatic patients. So back to public health, this testing is not a substitute to good public health and good vigilance of our patient. And this is the worry always. One reason there are so many cases of Singapore is Singapore does testing on all the foreign workers. And that's why they got 40,000 cases now. So in our case, we do not do on all the foreign workers. We do what we call smart targeted testing. And at the end of the day, Alhamdulillah, we are proven to be right, because we don't have to spend too much money. We do good vigilance work, good public health monitoring, closing down places where there is problem. And Alhamdulillah, it works. This is why I said everybody must write our own experience, publish it as a case report, publish it as an observation study, so that we can share experience, inshallah.
Yes, thank you, Professor Rashid. It's really good if all the FEMA countries can probably follow the protocol that Malaysia has done. And then I will go to Dr. Kusbarianto. Probably we hope that we invite you to give your opinion about the last question from the audience. Dr. Kusbarianto, yes.
Oh yeah. Yes. Okay. Thank you. I think the policy and management and COVID management in Indonesia, I think is not serious, but we must become a role model. We lecture on all of doctor, become a new become role model to the people. So we must conscience with COVID protocol. So the statement of new normal is not good, but I think menyesatkan gitu new normal. So we must become a role model. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. So you think that we must aware?
jangan nyalain inilah pemerintah kita. Masyarakat kita sudah diatur.
Yes, that's all. That because we have a very big population, 270,000. 262 million.
And spread out in 17,000 islands.
Yes, it's quite difficult to handle those quite population, big populations.
Yeah. Okay.
I guess we come to the end of the session. I would like to thanks for all the speaker here because for the time and then because they you all give us a very good insight for us to bring back again and then yes again I hope that there is a last speech from our dean Prof. Sharifuddin, probably you want to give us any ending notes?
Closing remarks.
Closing remarks, yes.
Maybe you can close statement from Prof. Rashid and Prof. Iqbal.
Oh,
and Dr. Iqbal.
Yes.
Yes.
Okay. Yes. Yeah. Before we going to the closing remarks from our dean, Prof. Sharifuddin, probably we will invite all the speakers to give the closing no actually the what do you suggest for us? What do you expect us to do regarding this situation? Please, Prof. Rashid.
First, I thank Allah Ta'ala for making this meeting a success. I see so many people attending and listening. Many are young doctors or medical students. I think it tells us that in this challenging time, we are, alhamdulillah, still hungry for knowledge. And
Yes.
we, as you know, seeking knowledge is something which is very blessed in Islam. So we, especially in cases like this, where it is so new, we've got a lot to learn. Point number one. Point number two, what we learned from COVID is that, you know, if we get our act together, if we do best practices, we share experiences, and then we remain humble, inshallah, we can, you know, we can overcome it collectively. I notice countries which are suffering, especially Brazil and North America, because they are not humble enough, and their leaders are not following the experts. Politics is more important than science. That's the problem. So I think this is a lesson which we learn, and I think we as healthcare workers must be brave enough to speak up for truth. And truth in this case is good science, and may Allah Subhanahu wa Taala help us. Billah, if this have ever happened again, we will probably be more prepared, inshallah. So Allah give us knowledge. Allah wants us to explore more knowledge. Once we get the knowledge, we must share quickly. Do not be arrogant, and the rest. Once we do our effort, we leave Allah Ta'ala to give the outcome. Wallahu a'lam.
Thank you, Professor Abdul Rashid. And the second from Professor Iqbal Khan. Please give us your last message.
Sister and brother and sister in Islam, it is time that we were waiting to meet in CIMCO. This is a very good effort. I strongly believe that this effort should be continued. Maybe next time we can have some specific topics on the related to current epidemics, or maybe our own problems. We had an education problem in different institutions. Suddenly the things to online, everything changed to online because of the lockdown. So we adopted new procedures, and we got to do few new things during this period, and we have done a lot of we experienced something probably new in this period, and what we will be doing in the current coming days after this post-COVID era, how the education and the medical practice will look like. It's very important, and we should plan earlier. And alhamdulillah, the Muslims around the world, they remain very proactive. But unfortunately, we couldn't be able to educate some our public at large, and this could have been done through our ulama, our religious scholars. our medical fraternity, particularly in Pakistan and probably in Indonesia, failed to convince our the clergy or uh, the religious leadership to come up with the solutions. And it is amazing that the brother, he presented a very attentive aspects of public health concerned about the epidemics, which was 1400 years back. But even our most of the ulama, they are not very much aware about the management of this condition, or pandemics or epidemics in Islamic Islamic history. We have a lot of things to share, inshallah, and I think that we should continue these webinars in future as well.
Yes,
Maybe
inshallah.
other universities should be given the opportunity to host this, and more international speakers should be invited from the other countries. I regret that we couldn't hear the brother from Turkey, but hopefully, inshallah, widely circulate, then we will get more good speakers. Always, the brother of the Rashid said, strive for the best, because in Quran, several places, and I quote one ayah, الذي خلق الموت والحياة ليبلوكم أيكم أحسن. That Allah subhanahu wa ta'ala has created the life and death. These are the only two things we encounter in our life. The life and death has been created to test us who is doing the best of deeds in our lives. And that best of deeds is our professional practice, our daily life, our interaction with other people, our social action, and our top of that, our ibadah. And our ibadah should not be segregated. It should be related with our every day of life. So this is what I wanted to say, and thank you very much. And it's a very good initiative. I welcome whenever, inshallah, we will repeat it. And the CIMCO, if give tasks to any institution, I think they should willingly, we should accept and organize these webinar in future. And they should, this is the only way we communicate with each other. There's no our meetings were postponed, as Brother Abdurrashid asked in the beginning. We were trying to hold it in April. They postponed to till September, but I have strong doubt that we will be able to hold it in September. So this is because of the prevailing situation because of the travel restrictions as well. So inshallah, Allah subhanahu wa ta'ala will give us the chance to one thing which I observe over the period of time, the virulency of the virus is decreasing. So I don't know exactly, the biologists around the world, they might be knowing why, but the virulency, even in the West, the virulency of the virus is not as strong as it in the beginning. So hopefully the things will become better over the period of time, and we will be able to do more work, inshallah. Thank you very much.
Thank you very much, Professor Iqbal. This is a nice messages from for all of us. And then next, Dr. Edward, maybe you have last a message for the participants. Dr. Edward and Dr. Kusbarianto. Dr. Edward, please. Do you have any messages for the participants? Dr. Edwards, it seems that you're quite difficult to unmute your audio. Okay, Dr. Kus. Okay, Dr. Edward, please.
Thank you, Doctor.
Dr. Edward, you are muted yourself. host, please host help Dr. Edward to unmute himself. Okay, we move to Dr. Kusbarianto first. Maybe you have the last message for all the participants here. Dr. Kus, yes, please.
Yes, thank you. I think most of the people now boring, boring stay at home, boring work at
Yes.
home, and boring to conscience with the COVID protocol. So I
Yes.
think as a Muslim we must conscience with this protocol, like COVID protocols, and become a role model for the people. I think no this statement. Thank you.
Okay, thank you, Dr. Kus. Quite short, but exactly that's what we should do to be disciplined for ourselves. Dr. Edward, can you unmute yourself now? Okay, if quite difficult for you, so we are going to the last closing remarks. We will invite our Dean, Medical Faculty of Universitas Muslim Indonesia, Professor Sharifuddin Wahid, to give his closing remarks for all of us. Professor
Thank you very much. I'm very happy because we'll be finished soon. Alhamdulillah wa syukurillah, the seminar will be finished soon and already running well. We get so many information about COVID-19. And the second one, as the host, I would like to ask for your apology for any inconvenience or any insatisfaction during this running seminar. And the last one, COVID-19, so many disadvantages, but also maybe COVID-19 have advantage. Let us looking for the advantage of the pandemic COVID-19. Saya kira itu, and I would like to ask also the chairman of WOKI to give not close remark, but what the next will we do. Okay.
Dr. Iwang, please.
Thank you, Prof. Rashid, Prof. Iqbal, and Prof. Wawang, Prof. Sharifuddin, and Dean of Medical Faculty in WOKI members. I'm sorry for this inconvenience about we postponed the second serial because my expert brother almarhum Ibrahim Sule is passed away. So until now we have not got substitute yet. So we postponed the second serial in online until Ba'da Idul Adha, maybe in 8 August, and the host is UHAMKA University. The dean is Prof. Wawang. Maybe Prof. Wawang give some information. Thank you.
Thank you, Dr. Iwang. Yeah, I just wait for your participation at 8th of August. Your participation is very useful if you can join with us. Thank you.
Okay. Thank you, Prof. Wawang. I would like to say thanks also to all the speakers for all the presentations. Give us a very great insight here. And thank you for our Dean as the host of this seminar, to Dr. Iwang as the chairman of CIMCO, and to Professor Abdul Rashid as the General Secretary of FEMA. And this is this is the flyer for medical education in COVID pandemic again. And I guess we come to the end of our session. Thanks again to all all of the participants here that stick until this time, and because we are now in time for Salat Ashar, then we close the seminar here. And thanks again for the speakers. Thanks again to the committee and also to the participants again. And inshallah, we will meet in another session, in another series of CIMCO seminar. Inshallah, Ba'da Idul Adha.
8 of August.
8 of August.
Yeah.
Okay. And we will close this seminar with the reading Alhamdulillah.
Thank you, Prof. Rashid. Thank you, Prof. Iqbal. And
thank you, Prof. Rashid. Thank you, Prof. Iqbal.
Thank you, Prof. Rashid. Thank you, Pak Iwan.
Salam Prof. Wahid. Salam dari saya.
Salam Prof. Wawan.
Pak Iwan, salam dari saya. Terima kasih. Pak Suhana. Hei, apa kabar nih? Habis operasi ya Anda?
Alhamdulillah, Bro.
Pak Nasruddin ini operasi aja nih.
Urus istri orang lain dulu, Bro.
Thank you, baik sampai nanti ya. Terima kasih semua.
Ya, terima kasih. Terima kasih banyak, Prof.
Assalamualaikum.
Terima kasih banyak, Prof.
Terima kasih banyak, Dok.
Iya, terima kasih banyak, Prof. Dok.
Ya.
Ya, insya Allah ini.
Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Prof. Sarifudin, Dr. Surhana, Dr. Ida.
Iya, Dok.
Terima kasih, Pak Iwan.
Ya, Dok. Itu, Dok, yang
Siap,
meninggal,
ya.
yang meninggal siapa ya, Dok?
Yang meninggal tuh dinnya tip fakulti
Iya.
Madaniyat University. Jadi dekannya Fakultas Kedokteran Madaniyat University, sehingga Prof. Hasannya nggak bisa ngisi karena dia sibuk itu takziah di sana.
Iya, Dok.
Yang ke session yang kedua itu kamu masih ingat nggak Ibrahim Sule yang dari Nigeria?
Iya, yang SPO.
Iya. Ingat,
itu
Dok.
kemarin
Itu ya?
tanggal 9 sudah confirm, sudah pasti, udah siap dan sebagainya. Nah, 2 hari sebelum hari ini, hari apa itu? Saya kan itu kan yang dari Inggris itu Dr. Wajid itu is confirm bisa tanggal 26. Nah, terus saya kirimi semua speaker, saya kirimi jadwalnya. Terus dia tanya, "Loh, kenapa kamu kok masih masukkan Ibrahim Sule di dalam list pembicara?" Saya bertanya, "Ada apa? What the matter?" Saya bilang gitu. Dia pass away 2 days ago. Masya Allah, saya nggak tahu. Jadi 2 hari sebelum saya konfirmasi akhir untuk semua penjara, kan semua penjara sudah confirm tuh, termasuk Dokter Nas, Dokter Eka, Wajid dari UK, itu sudah confirm semua, sudah saya kirim semua. Ternyata, nah itu. Kemudian saya cari pembicara dari Jordan, itu juga kebetulan tanggal 26 tuh udah pada penuh semua, sehingga tidak bisa juga. Dan lagian COVID di sana tidak merajalela seperti di tempat yang lain
Di
katanya.
tempat,
Jadi jadi untuk experience dia untuk COVID dia nggak terlalu ini, sehingga lain kali aja katanya. Jadi kita masih belum dapat pembicara untuk yang pengganti Ibrahim Sule itu, almarhum itu.
Ibrahim
Tapi
Sule
kan-
itu yang
Objin.
Objin.
Ada yang
saya kenal
tinggi
Rai itu.
besar itu.
Dia uroginekolog di sana, uroginekolog.
Iya, uroginekolog. Itu kan nanti itu saya tandemkan dengan ini Dokter Nas gitu kan.
Iya, aduh.
Supaya bisa ada diskusi tentang navigating pregnancy di dalam COVID area, COVID pandemic era ini kan.
Experience di sana Nigeria dan kita ya.
Iya, ternyata ya itu kejadiannya. Saya juga katanya mendadak juga. Saya konfirmasi ke Prof. Rashid, memang
besar juga badannya itu.
Yang tinggi besar.
Enggak, kecil, malah yang tinggi besar Audi, sekretarisnya dia.
Saya kira yang Dr. Ibrahim Sule yang tinggi besar itu, Dok.
Enggak, yang tinggi besar itu Audi. Itu yang memberitahu teman-teman di Exco. Tapi kan saya nggak masuk di Exco, sehingga saya nggak tahu. Sedangkan di project nggak di share itu kematian beliau. Nah, saya tahunya dari Dokter Wajid itu, terus dia kirimkan waktu videonya waktu pemakamannya Ibrahim Sule. Astagfirullah, saya bilang itu innalillahi wa inna ilaihi raji'un, saya bilang gitu. Nah, sampai sekarang saya belum dapat nih untuk speakernya, saya coba cari dari.
Tapi dokter ini dok kan pindah ke bukan itu ya, ke dokter Prof Hasan yang dari Turki kan pindah, nggak jadi hari ini, jadi bukannya beliau mau dipindahkan ke seri kedua.
Ya, nanti itu, tapi kan nanti jadinya ini internasional speakernya jadi cuma satu, cuma apa 2, kita kan maunya 3 gitu kan.
Ya.
Jadi supaya ini tadi akhirnya cuma jadi 2, mungkin ya itu. Coba saya pindah ke sana aja nanti ke tanggal 8 itu tentang ini.
Iya, Dok.
Supaya ada.
Iya.
Karena temanya itu kan Dokter Wajid itu bagus untuk safety BCLS itu. Kan beliau menginisiasi ini apa pelatihan basic life support untuk masjid-masjid British ya. Itu di YouTube-nya banyak dia. Ya. Jadi gitu. Terima kasih dokter.
Iya.
Dokter.
Iya dok. Iya terima kasih dok.
Panitia. Mohon maaf kalau ada salah kata.
Dok, kenapa nggak muncul mukanya, Dok?
Halo, kenapa?
Anda sekalian yang saya cintai, teman sejauh sekalian para dosen, ya, kami mengingatkan kembali insya Allah ya, sebentar malam acara Asia malam ketiga. Ya, Ayahanda Ketua Bagian Objin FK UMI, almarhum Profesor Dr. Arifin Juwana SP Konsultan. Sangat diharapkan kehadirannya ya, insya Allah.
Iya, insya Allah. Ketemu lagi sebentar malam.
Ya. Assalamualaikum.
Waalaikumsalam. Kita mau salat asar ini. Ya.
Dokter Handayani, makasih banyak dok.
Ya, sama-sama dokter. Terima kasih.
Dokter Handayani masih di jalan dok.
Terus sampai.
Dok, masih di jalan ya dok.
Dokter Handayani, apa kabarnya dok di situ Surabaya? Apa kabarnya dok? Surabaya dok.
Alhamdulillah kita baik-baik.
Alhamdulillah.
Baik dan antara baik dan tidak baik, tapi kita bersyukurlah semuanya masih sehat begitu.
Iya. Terakhir kita kemarin ketemu di waktu Koki di Surabaya.
Oh iya.
Iya dok.
Nggak pernah onsite lagi kita, belum onsite belum ketemu lagi. Mudah-mudahan cepat
luar
ini.
Luar biasa ya.
Alhamdulillah dok.
Iya dok.
Ya, mudah-mudahan semua sehat ya teman-teman semua.
Amin.
Sehat di sana juga dok. Iya.
Sama-sama dok, sehat-sehat juga semua.
Saling berdoa, mohon izin teman-teman.
Ya dok, makasih dok.
Terima kasih ya dok.
Ada Ibu R tadi, Ibu Erlinda.
Siapa?
Dari UII. Masih
ada dokter. Tadi masuk sempat dokter Linda, Ibu Linda masuk. Tapi sebentar sekali terus. Iya, Ibu Linda sudah enggak ada.
Ibu R sudah keluar ya? Enggak sempat.
Ini Umu Kalsum Malik, Dokter Ega ya? Dokter Ega ya ini? Halo, Dokter Ega ya? Halo, dirimu kah itu? Mana ini enggak kelihatan mukanya? Terima kasih ya, mewakili siapa? Mewakili Pak Dekan?
Mewakili semuanya.
Mewakili semuanya. Iya, padahal kan enggak ada di sini, enggak hadir. Nanti insya Allah gabung ketemu lagi di next seminar. Ya. Terima kasih ya, Dokter Ega. Terima kasih.
Ya.
Terima kasih semuanya. Kita saya live.
Terima kasih Dokter Solhana.
You're welcome.
Terima kasih dok.
Dan Dokter Edo, terima kasih Dokter Edo.
Mana Dokter Edo? Suaranya enggak keluar tadi, kesian.
Bermasalah kianunya kodong tadi.
Untungnya selesai mi presentasi. Thank you very much for all the participants.
Jangan lupa sebentar malam.
Ya.
Anak-anak juga ya semua.
Masih bertanya semua tinggal. Sudah minta, host silakan ditutup. Kayaknya kalau host tidak end meeting ini enggak ditutupin ya.
Assalamualaikum.
Assalamualaikum.